Hello everyone. I wanted to do a brief review of our T1. I've been told by some that you haven't felt very comfortable with the ventilator. You haven't had much exposure to it, and that the initial training might have been a little too involved. And on the initial training, we did go through all of the modes, which I thought was essential for really understanding this ventilator. But now we're going to talk about just the most common modes, the stuff that you're most likely going to use for the majority of patients, if not all of them. So you see that this screen is set up exactly like ours. You have ASV, NIV, and CPR. It's pretty self-explanatory. ASV is used on any intubated patient that's not in cardiac arrest. NIV is used on any non-intubated patient that's conscious, awake. That's your non-invasive ventilation. That's CPAP, BiPAP. And then you have CPR mode, which is used for patients that are in cardiac arrest that have some kind of advanced airway, endotracheal tube, and possibly an iGel, depending. So when you turn the ventilator on, this is the screen that you see. All you have to do is select your mode, the gender, and it is good to put in their height, especially if you're using ASV. NIV and CPR, they're pressure modes. The volume isn't dependent on their height, but the pressure inside their lungs. So it's not that important. So of course you're going to do your pre-op checks, but we won't do that right now. So if the patient is intubated, in ASV, you set a minute volume. Now, how do you calculate minute volume? Well, that is respiratory rate times tidal volume. So if my respiratory rate is 10 and my tidal volume is 500, what would be my volume per minute? Well, it would be 50 times 10, so that should be 5,000. So my overall minute volume, the total of the breath or the volume of air moving in and out of my lungs in each minute should be 10 breaths per minute times 500. Now this minute volume changes depending on what's going on with the patient. So imagine we had a patient that had metabolic acidosis. They had DKA or sepsis, and they're metabolically acidotic. They have a low pH. Their body's used up its bicarb, and we want to keep their CO2 low. So we give a higher minute volume, so more air moving in and out for each minute to blow off that CO2 to compensate for metabolic acidosis. So we would start with a minute volume that's higher, around 120. Now the same is true for your end-tidal CO2. If your end-tidal CO2 is too high and we want to bring that down, then we would go up on this minute volume. Because imagine that you have a patient that's not on the ventilator. You're just squeezing the BVM. If you want to bring the CO2 down, you increase the rate. And if you want to let the CO2 go up, if you've hyperventilated too much, then you go down on the rate. Now there are two things that affect your end-tidal CO2. That is rate and volume. Now, when it comes to other patients, such as COPD or asthma, they don't need a high minute volume. In fact, at baseline, their CO2 is a little elevated. And what we do when we lower the minute volume, if we start off with a minute volume around 90, 80, something like that, we're going to permit their CO2 to go up higher, but we're also giving the ventilator more of an opportunity to decrease the rate because it doesn't need to increase that rate as much to maintain that same minute volume. Now, when we're talking about PEEP and oxygen, generally a good baseline for every patient is a PEEP of 5. And a good oxygen for most patients starting off is about 50. Now, what we do when we have a patient that is on these settings, that is not being oxygenated effectively, we generally increase both the PEEP and the oxygen percentage in tandem. And if you look on your protocol, there is actually a PEEP FiO2 chart. Now, you don't have to strictly adhere to this PEEP FiO2 chart, but it is a good rule of thumb. So patients that are going to need higher PEEP or FiO2 or generally our ARDS or our pneumonia patients, those are the patients with these stiff lungs. Remember, COPD patients have more compliant floppy lungs. So we gradually go up. We try to do this in tandem with our PEEP and our FiO2 until we achieve our target SpO2. And I hope that that makes sense to everybody. Higher PEEP on an intubated patient is okay, assuming that their blood pressure isn't marginal. They do need a good blood pressure. And if they're hypotensive, I would be cautious with increasing their PEEP too much. So your run-of-the-mill intubated patient, let's imagine that they don't have any lung pathology. They're intubated solely for airway protection. Well, they just need a normal minute volume, which would be 100% based on their gender and their height. A normal starting oxygen percentage is around 50-40%, and a PEEP of 5 is pretty much satisfactory for every patient. So we've got all of this typed in. We're just going to go ahead and hit start ventilation. So there are a number of graphs that you see right here. This is your ASV graph. This is just a pressure waveform. Over on the left, you'll see your tidal volume here. This is your expired tidal volume. So once the ventilator delivers the breath, this is what is coming out. And it's generally a good surrogate of how much air they're getting. This is their minute volume. And the ventilator determines their minute volume based off of their height and their gender and the minute volume that you have set. Now you can change this graph. You can go from this ASV graph to the dynamic lung graph. And it's essentially whichever one that you're more comfortable with using. I personally prefer the ASV graph just because I feel like it gives me more information. And this ASV graph can tell you a little bit about what's going on with the patient's lungs. If you're ever on the fence about what's going on, do they have ARDS? Do they have pulmonary edema? Do they have COPD? Is it an obstructive lung pathology, meaning asthma or COPD? Do I need to decrease the minute volume? Or is it an ARDS patient in which I would need a higher minute volume? Or maybe it's a patient that has DKA and you're not sure if they have an obstructive lung pathology. So maybe the patient has COPD and is also a diabetic and is in DKA, and you're not sure if it would be appropriate to increase that minute volume to compensate for their metabolic acidosis in order to risk the possibility of breath stacking because they have underlying asthma or COPD. This graph right here can tell you a lot about what's going on with their lungs. So when looking at this graph, I'm not concerned about a whole lot on it. I am concerned with the shape of this box. Now, this box is pretty much a square, right? It's pretty much even on both sides. Now, if we change our patient to someone that has COPD, let's give them a little bit of a rate here. So we have a patient with COPD. You see that the shape of the box changes. And what the ventilator is doing at this moment with each breath is it's measuring how compliant the lungs are and how long it takes that patient to expire. You will see right now that the box is pretty tall and it's narrow. So it's tall and narrow. it has restricted the rate. So it's dropped that rate down. It is dropping that rate down because it has sensed that the patient is taking a long time to exhale. So it's bringing the rate down to give the patient a longer exhalation time. And it has noticed that the lungs are very compliant. Remember, COPD patients have very compliant lungs. So it is allowing a high tidal volume. So it can drop the rate, increase the tidal volume. You'll see the tidal volume here is 775. It's dropped the rate, increase the tidal volume to meet the minute volume target based on what we have set. Now, if this was a COPD or asthma patient, we'd start off with a lower minute volume to further allow the ventilator, or to give it permission, quote unquote, to drop that rate even further if it needs to. And you see that it did. Its target is a rate of 9 now. If this patient were to have ARDS, stiff lungs, you'll see that the rate, or you'll see that the shape of the box will change. So let's give it a few breaths to adjust, and it will gradually do so. So with ARDS, the lungs are stiff, and we can apply this to patients with pneumonia, with pulmonary edema, etc. You don't want as high of a tidal volume, and the ventilator will sense this as increased resistance, but you don't want as high of a tidal volume because the lungs are more susceptible to damage. So you'll see the ventilator shrinking the tidal volume. And I'm already getting an alarm here. Let me silence that for just a second. The ventilator shrinking the tidal volume, right, delivering a lower tidal volume, and a higher rate to still meet that minute volume target. Now, why did we get an alarm here? Alarms can cause a lot of issues in the terms that it throws us off, it makes us confused, and makes us a little anxious. But it's not much to be worried about. You'll see that the minute volume here is still 6.3%. We can even increase this minute volume to what we would want in a patient with ARDS, which is 120, and we can still meet the minute volume target, or we should be able to, because this patient doesn't have any issues exhaling, right? The exhalation time should be normal because there's no issues getting air in or out. The issue is with stiff lungs. So you will see the ventilator increasing the rate, and it'll be reflected here. And it's still dropping that tidal volume because the lungs are not very compliant. Now, what do we do with this alarm? First, we acknowledge it. We silence the alarm, which we did so that we can think clearly, but we don't ignore it. We go to our alarms panel here, and we can see that the alarm that we were getting was a low tidal volume. It's set to 350. That's the limit. That is the alarm limit. I can go down on this. All it does is it's a trigger for the ventilator to alarm. Now that the tidal volume is higher, maybe the patient's lung physiology has changed. Remember, the lungs are dynamic. The compliance is going to vary breath to breath. And the ventilator during transport may need to lower the tidal volume because the resistance in the lungs has increased. But if the tidal volume goes below 350, I can simply lower this down a little bit more just to clear that alarm. Where you want to be concerned when you adjust any of these is with your pressure limit. All of these other things, they don't matter a whole lot. Let's imagine the patient's on the ventilator and they're starting to wake up from sedation. Their respiratory rate's going to go up because they're going to be anxious because they have a rigid piece of plastic stuffed in their throat. Well, I can acknowledge this alarm, silence it, increase my rate just to clear that alarm, and then I would treat my patient. The same holds true for the minute volume alarm. If the patient is waking up and you see a lot of these pink arrows indicating that the patient is taking a lot of spontaneous breaths. You also see a Curie cleft on your end tidal, and your end tidal rate will start going up. But that's going to increase the minute volume because the patient's waking up, they're breathing faster, they're taking deeper breaths. I can go in here, change my alarm parameter, increase the minute volume, and then sedate my patient and treat my patient accordingly. Now, when it comes to pressure limits, let me see if I can simulate this. Let me decrease the compliance here. If I decrease my compliance, you should see the peak airway pressure start to rise. You'll see the peak airway pressure start to rise, and then you will see the tidal volume decrease because the lungs are less compliant. So we'll give it a few breaths to kind of adjust and measure the compliance in the lungs. And you'll see our ASV graph is changing. You'll see the peak pressure going up. Now, if there's very little compliance and you start getting higher airway pressures, you might get a pressure limit alarm, and we just did. So I got a pressure limitation. You'll see two lines here. There's a blue line and then there's a red line. So what happens when that pressure reaches 30, which is where the blue line is? Well, it's okay that it gets up there. When it reaches that blue line, the ventilator just stops delivering a breath. If it were to reach the red line, which theoretically it shouldn't, the ventilator should stop it at the blue line, but if it reaches that red line, it's going to dump the breath. It's going to open that exhalation valve and let all the air out. So we keep getting this pressure limitation. We might be tempted to go to the alarms and increase this. So let's take our pressure from 40 to 50. Now, what line shifted? Well, the red line and the blue line both shifted. So the blue line went from 30 to 40. Does that make sense? The blue line went from 30 to 40. Now we are permitting this ventilator to deliver a breath until it reaches a peak airway pressure of 40. This could be bad. All right. When you're getting in the mid and high 30s in your peak airway pressure, you are exposing the lungs, the baby injured lungs, to increased pressures that could damage alveoli and cause some injury to the lungs. So it is generally not advisable to increase this alarm parameter. And this is pretty much the only one. You may be in certain situations where the patient has severe burns, right? They have inadequate chest wall expansion due to burns, or maybe you're doing CPR and you're not getting any tidal volume because the compressions are limiting or preventing the monitor from delivering that pressure. At that point, if the patient has inhibited chest wall expansion due to burns or something else, and you have made the conscious decision that it is okay to increase this pressure limit so that you can get some ventilation to occur, then you can do so. But I would not want to allow the ventilator to go above 40. Although we set this to 50, we've set the pressure limit to 50. Remember, this limit is when the ventilator opens the exhalation valve and dumps all the pressure. But by controlling this one, we're also controlling the PASV limit, which is the blue line, where it stops delivering a breath once it reaches that. So this is mostly everything you need to know about ASV, how to manage an intubated patient. We can look over the protocol real quickly. You'll see if they have metabolic acidosis or fever, You start at a minute volume of 120%, and you gradually increase that to slowly bring down the entitled CO2 just on the lower end of normal. And it's kind of the same with a traumatic brain injury. Remember, with TBIs, we are no longer routinely hyperventilating the patient. Generally, we just want to lower the entitle to the lower end of normal if they are showing signs of herniation, meaning they meet Cushing's triad, they have unequal pupils, they're posturing, they're having seizures, etc. Then it is appropriate to lower the entitled CO2. If they have ARDS or pulmonary edema, you want your minute volume to be greater than 120%. To maintain eucapnia, you can titrate this, but the key here with CHF and ARDS is your PEEP and your FiO2. These other settings that you see, the tidal volume, the rate, the I to E ratio, you do not directly control that in ASV. You do not enter the rate. The ventilator determines the rate based on the minute volume you have set, how compliant the lungs are, and how long it takes that patient to exhale. The ventilator does all the work for you. You just have to know how to adjust PEEP, FiO2, minute volume, and troubleshoot alarms. And I hope that that was useful. Now, how do I get out of this setting? There are a few other monitoring parameters that you can look at. You can hit the monitoring box. You can go through these various options, 1, 2, or 3. On number 1, you can see the I to E ratio. So if I had a patient with COPD, you'll see that the lungs are very compliant, but what it's going to do is it's going to, let me look at this, it's going to change your expiratory time constant. So that's essentially how long it takes a patient to expire. You'll see normal should be less than 0.6. If the patient has normal exhalation, it should be 0.6 or less, and that's exactly what this simulator has designated as normal, as 0.6. When you go up to COPD, the expiratory time constant increases significantly. And now we're getting a high tidal volume alarm. I can silence that, go to alarms. Tidal volume, I can increase that. And that cleared the alarm. So going back to monitoring, you'll see the expiratory time constant. You'll see the I to E ratio, which for COPD it should increase, but again it depends on, this ventilator is a smart ventilator. It's like the Tesla of ventilators. It looks like it's doing a pretty good I to E ratio, but if that I to E does not look that long, I need to think, well, if I'm clearly seeing a COPD or an obstructive waveform here, why? I look at my minute volume is pretty high. Let's see if I decrease this, if it changes the I to E. We'll give it a few, we'll let it deliver a few breaths to adjust. And you'll see that it didn't extend that expiratory time a whole lot. If I have reason to believe that the patient is breath stacking, I can decrease this minute volume a little bit more, with the understanding that my CO2 is going to increase slightly. Something else that you'll find useful on this monitoring window is the V-leak. So this is useful for a number of things. We can actually see how good of a seal we have with our endotracheal tube. If we have a large leak, we're going to get low tidal volumes. Large leak, low tidal volumes. So if we have this large leak, we have to think of things that could cause an inappropriate seal in either our circuit or our endotracheal tube. Maybe the pilot balloon, is it inflated enough? Maybe we need to inflate the cuff just a little bit more. Maybe the cuff is ruptured, because that happens. So this can kind of cue you in on a lot of things that are happening with your equipment and with your patient. Now, if you have the patient, if you have an eye gel placed, and let's imagine you were resuscitating a patient in cardiac arrest, you got a pulse back. Okay, now what? Well, we know that with an eye gel, we can switch to ASV. But, however, because ASV depends on a lot of feedback from the patient, you need a really good seal on that cuff. And what Hamilton has told us, they've said, you can use ASV with a supraglottic airway device as long as the V leak is less than 30%. Now let's go ahead and switch back over. And let's say I want to put it in CPR mode. Maybe this patient that we have intubated just went into cardiac arrest. What do? Well, where's our CPR mode on here? It's not listed. It's not listed as CPR mode in this menu. So we have to do a few things. We put it in standby real quick while someone's starting CPR. We hit adult ped, hit CPR, and then start ventilation. You'll see that when we're in CPR mode, we're in a pressure mode. We no longer set a minute volume, but we set P control. Now, what is P control? Well, it's essentially how much air we're allowing the ventilator to deliver up to a certain pressure. So once it reaches that pressure, and then you can clearly see that the peak pressure is 25, so it's that plus the PEEP, it's going to terminate the breath. So instead of setting a tidal volume to target, it's targeting a pressure, and we're getting the resulting tidal volume. Now this is defaulted to 20. If the patient's in cardiac arrest, you've got them on the vent, you're doing CPR, a P control of 20 isn't a whole lot. And you can imagine that when you're doing CPR, you're going to be reaching that P control or that pressure of 20 early on. So you might have to, if you're getting extremely small tidal volumes, increase this a little bit to get higher tidal volumes. And you're going to get this pressure limitation here. You're going to get it. But here's the problem. We do know that when it comes to pressure limitation, we don't want to go much higher than 40. Now, if they're in cardiac arrest, they're not going to have a compliant chest because we're leaning on it and we're pushing on it. It might be okay to increase that a little bit. It's still going to terminate the breath. If we set this at 50, that's the red line. It's still going to terminate it at 40. Now we're getting a lot of other alarms here. And if they're actually in cardiac arrest, we're probably going to be getting a low tidal volume alarm, which we might have to drop that. Now these are appropriate settings for cardiac arrest, but there are a few other things that you might have to change. You will have to go into control. And on our ventilator, it will not default the rate to 10. It'll only go down to 12. So we'll have to change that from 12 to 10. And you want to make sure that the flow trigger is off, or as high as it'll go. The flow trigger determines how much air or how much flow the patient has to bring in to trigger a breath. If they're in cardiac arrest and we're doing CPR, we don't want them to be able to trigger a breath. The recoil, the chest wall recoil, can generate some negative flow and trigger the vent. We do not want that to happen. And that's essentially it for CPR mode. Now, if we get a pulse back, we would essentially just have to switch it to ASV. Now you can hit modes. You can hit modes and go to ASV, since that's familiar terminology and we know how to find that. But if you wanted to, you could put it in standby, go to adult ped and hit ASV and start ventilation. Now, what about non-invasive ventilation? This seems to confuse a lot of people, but it doesn't have to be that complicated. This was defaulted a little high. Let me start off here. This is our default for non-invasive ventilation. When you start it up, you're going to have a P support of 5 and a PEEP of 5. Are we in CPAP or BiPAP right now? Well, we're in BiPAP. We have two different levels. We have a baseline of PEEP of 5. You can see it. Let me fix this. Alarm parameter. So I'm just going to decrease that a little bit. Clear that alarm. We have a baseline PEEP of 5. So when the patient expires, they're expiring against 5 of PEEP. When they take a breath, the ventilator adds 5 on top of that. So it provides inspiratory support. The total is 10. We're getting a peak pressure of 10. So essentially what our settings are right now is 10 over 5. In the hospital, they have standalone BiPAP machines unless they're using a ventilator. But a lot of ERs use standalone BiPAP machines. If you're doing a transfer, they might say that the patient is on 10 of BiPAP and 5 of EPAP, which we would know to put in 5 of P support and 5 of PEEP, because that would give us our 10 of inspiratory and 5 of expiratory. Now, what if we wanted CPAP? Well, if we wanted CPAP, we would just go to 0 on the inspiratory. Now we would have a constant PEEP, and we would just dial it in how we normally would. Do we want 5? Do we want 10? Generally, if they have pulmonary edema, we'd probably start around 10. You'll see that as soon as I selected that, the baseline changed. We don't want P support. If I dial in P support, then you can see that it is adding that on top of the PEEP. So now we're bi-level instead of just CPAP. Something to note is on BiPAP or CPAP, we do not want a cumulative pressure above 20, because a little bit further than 20 or a little bit higher than 20, the esophageal sphincter can spontaneously open and air can be forced into the stomach. Now, when would you choose BiPAP over CPAP? Well, it's pretty simple, actually. We have to ask ourselves, does the patient have an oxygenation issue or do they have a ventilation issue? Who do we mean when we say oxygenation issues? Well, we're talking about our pulmonary edema, our ARDS, our pneumonia patients. They don't have anything restricting the flow of air in or out. They can get air in, they can get it out. The problem is at the level of the alveoli. Remember, P support or BiPAP provides inspiratory support. For a patient that is breathing normally or moving air in and out normally, they just need PEEP or CPAP. They don't need the additional inspiratory support. So we can start them off with CPAP or just continuous PEEP here. Low tidal volume, let me adjust this. Now, who needs BiPAP? Well, it's the opposite patient group that we just discussed. It's our COPD, our asthma patients. The patients that can get air in, but they can't get it out. Now, we almost always want to keep a low PEEP with them, because remember, they can get air in, but they can't get it out. We don't want anything obstructing their ability to adequately expire. So for them, the go-to setting, the most common setting, is 10 over 5, which on our vent, we would have 5 of P support and 5 of PEEP. They would get a inspiratory support of 10 back to a baseline of 5. These patients, although they're generally oxygenating okay, these patients are generally oxygenating okay. So we don't usually have to do much with the PEEP. Now, it is possible to get mixed issues. Maybe they got pneumonia and COPD and they're having some reactive airway disease. Okay, we might have to change the PEEP then. But we never want our PEEP to be higher than our P support. But let's go back to our typical COPD patient. They can get air in, but they can't get it out. We have done what we can. We've decreased our PEEP. And honestly, if they're if they're having severe obstruction, if they're just breath stacking, they can't get that air out, maybe we'll take down the PEEP any further, but we never want PEEP to be higher than P support. If they start getting fatigued or they feel like they're not getting enough air in, the diaphragm is a muscle, and over time it becomes fatigued and that patient gets worn out. We can be clued in to this by a gradual, just the patient says they're not getting enough air, maybe the end-tidal CO2 is climbing. We can give them some more inspiratory support to make it easier for them to get that breath in. And we're going to continue our additional treatments of inline nabs, etc. And that is essentially the only modes that we're going to be using, and that is just the basic introduction or reintroduction to managing patients on the Hamilton T1. We can dive into more ventilator theory and more things that we can do with this ventilator later, but I really want to ensure that everybody has a good foundation and a good understanding of the ventilator. And if you've seen this and there's something that you're not 100% sure of or you're confused, come to me. Take it upon yourself to come to me, because I have no other way of knowing, and I need to know so that we can work through it and we can talk about it. Now, there are some other buttons on the side. If you are using an inline neb, they do recommend that you actually connect your nebulizer tubing to the side of the ventilator, and you use this function right here. You push that because it'll try to time the airsolation with the breaths, and it might be helpful. And if you get confused, it's probably okay to hook it up to another outlet. Now, I did briefly want to cover our post-intubation procedure because this may be new to some of you. I'm not exactly sure. So previously, the only option that you had for post-intubation management was Versed and fentanyl. We have now included ketamine to that. So remember, Versed provides sedation, but it doesn't treat pain. It doesn't provide any analgesia. We can assume that the patient is in pain because they have a rigid piece of plastic stuck in their trachea, and it is very uncomfortable and it's painful. I don't know from experience. But we want to provide analgesia and sedation. We can do this a few different ways. We can do this with some fentanyl and Versed. You do need dual therapy if you're using fentanyl and Versed. And it is recommended that you provide analgesia first, because analgesia first will decrease the amount of sedation that you have to give to the patient. Fentanyl is generally hemodynamically stable. Versed, not so much, but it's okay if you give it slow IV push, then you won't cause as significant hypotension. But if you have a patient that is borderline hypotensive, the blood pressure is marginal, maybe they have a high shock index, maybe they're tachycardic, volume depleted, acidotic, ketamine is what you want. Now, we can give ketamine 1 mg per kg IV, and you can repeat that every 10 minutes. This is 1 mg per kg IV. This is not a pain dose. Remember, our pain dose is 0.2 milligrams per kilogram IV. We're giving a fully dissociative dose IV. If we wanted to dissociate them IM, then it would be 4 milligrams per kilogram. If you give ketamine, since it has analgesic properties, you do not have to give fentanyl with it. You do not have to give fentanyl with it because it provides sedation and analgesia. Now, the fentanyl dose is a little different. It's different than our pain dose. The dose for post-intubation analgesia is 1 to 2 mics per kg. You can repeat that every 15 to 20 minutes. So if you're sticking with the fentanyl Versed cocktail, which is fine if that's what you're comfortable with, then try to provide some analgesia first. You can have a lesser dose of sedation. But if you're going with ketamine, it is 1 milligram per kilogram, and you do not need orders to administer the ketamine in this situation. I hope that you all have found this useful, and if you ever have any questions, do not hesitate to ask me. Thanks.